Let's get started, guys. Eddie is one of our past fellows that graduated 2012, 13.
12,
What
12.
was it? 12, and did an amazing job. His fellow class here was epic. I always tell the story that Eddie can basically consume anything at any temperature and any level of heat. We would go to a restaurant and there would be piles of hot sauce and it wouldn't phase him. He would go in the surgeon's lounge in the morning and brew a fresh cup of like steaming hot coffee and just like chug it. Like, this guy's unbelievable. He was a ton of fun, but more importantly, he's developed into a really pretty amazing surgeon. Has a pretty awesome practice up in LA. It took him a while to build it, but he stuck with it and has done really well. He's got a wife and a couple beautiful kids. And anyways, we're happy to have you, Eddie. We're proud of you and look forward to hearing what you have to say this morning about this.
Just in general, I created a talk about kind of just the first few years of private practice. I'm now 10 years into practice, so I don't know if I'm a young practitioner anymore. I'm probably more in the mid stages now, but wrote a talk just basically to focus on the first few years because there's an evolution that happens, as a surgeon. And I think the big things that we need to deal with are just kind of learning how to focus on what's important those first few years. I think the first few years you get out, you are influenced most by your fellowship and you want to continue doing what you've learned in the past. But I think sometimes you got to, be careful that number one, you're not your attending, and that, they have a lot of systems in place that you may not necessarily have. So I think you got to be careful and cautious with what you proceed in, in surgery and how you handle patients in clinic. I think the focus the first 2 years should be to be the best surgeon that you can be, really developing those skills because you are now going to be the primary surgeon on the case. You don't have that other person to help you most of the time and to guide you in the right decisions in a case. And as you start to develop your practice, there's many distractions that are going to be around. You've got a lot more free time than you've had in a long time, and the time is yours for the most part. Distractions, include things that are fixed, like finances, what you're getting paid, what your overhead is, if there's a track for partnership, and also your family, right? Those are things you can't really change. But others that are extraneous, such as relationship with industry, your friends, research, those are all things that you can kind of modify to kind of create your own practice. And I think sometimes those should be secondary those first few years, so that you can catch your bearings in your practice. Now, with that, there's I think you hear a lot of talk about having balance in your life, balance in your work life, your family life, et cetera. And I think that's also something that you'll need to adjust and learn how to adjust over time because of, again, the various distractions that come about. And lastly, your first few years in practice, I think there's going to be a big focus or the overlying thing on your head, like a big heavy cloud, are the boards. You want to try to pass your boards. You want to be smart about cases you choose for boards. And that is a big thing to think about. Now with boards, I think my big advice with your boards is always going to be, you got to be very careful about the cases that you choose for your boards. And that starts at day one. I hear sometimes people having advice that, oh, don't worry about it. Just be, once you start to get to the collections period, that's when you start to worry about it. However, if you do cases early on and they become a revision in your boards period, they'll ask you why are these cases being revised, right? So you got to be careful what you do early on. And honestly, I think you should be, not that you're doing anything that shouldn't be done. But you also have to be very careful until you pass. I actually know a few people from various fellowships, good fellowships around the country that actually did not pass over the past year or two. And I'm not sure if that's a COVID issue or they're an issue with them. But anyways, that they did not pass. I've heard of more people not passing that are closer to me than I have ever in the past. So just be careful with boards. I think just be very careful from day one on what you're doing. Now, I know the 3As, 5As always get talked about how to start your private practice, but I just wanted to just discuss them just briefly and how they've had an effect on my growth. The affability, likability aspect of it. I think this is very self-explanatory, but you want to be humble in clinic, the operating room, staff, nurses, conferences. If you come out with your guns firing and conference with elder surgeons and haven't been there very long, then they may not necessarily like that. So we've learned a lot in fellowship, and I feel like we know how to do things well, and we've been taught the right way. But you got to kind of pick and choose your battles in the situation. Availability, being around to be able to do inpatient consults, which I think sometimes are the bane of our existence especially when you're not on call. Having doctors are personally calling you to come see their patients. I mean, to vote in confidence in you. So it's different from our training, being a resident or a fellow, where you're like, darn it, another thing to do. This is something that can lead to more productivity for us, even the infections and compression fractures. And I just put a little comment about Gladwell that you never know when people are connectors or mavens. If you've ever read The Tipping Point, a patient from meeting you from there may spread the word to 5 other people saying, oh, I met this great spine surgeon today. And a lot of the times it's even non-operative things that consults that people will sit there and will spread the word. So I see that happen very often. So you just never know who you're going to meet. And I think communication with referring physicians is something that it goes a long way. Now, everybody gets our notes back to them, but in this modern age now with our EMR systems, being able to send direct messages or emailing, sometimes texting. I do that with a lot of physicians to keep up about patients with them, and I think they appreciate that a lot. So I've kind of gotten away from making phone calls all the time. I know other guys do, but I usually just kind of send a text or email since it's just hard to connect on the phone. Ability, you want to be well planned with your cases. And like I said, just remember you're not your current attending. You're not going to be able to do the 3-column osteotomies like you've seen in fellowship as smoothly when you're doing your first one. You have a system, but it's not going to be executed the same way. Really difficult laterals with a really bad scoli. It's not going to go the same when you do them your first few probably more times. You just have to remember that you've got the skills to do it, but don't expect that type of speed, and putting patient will be under anesthesia a lot longer. So just think about staging and those kinds of things ahead of time. And adaptability, understanding your whatever situation you go to, it's going to be different than where you trained. And you got to understand the employees, the work environment, and and with this, it's showing them a lot of appreciation. I think that goes a long way in developing your practice and respect around your staff and community. It's if you show that appreciation, even just saying simply thank you, simple, lunch, happy hour, whatever your hospital allows you to do, I think it goes a long way for people doing that extra work for you, people that are be willing to stay late for you to finish your cases. That helps a lot. The other thing I think is very important as you develop early on is if you can find, a mentor, somebody that can help you out with cases, and somebody, people that can give you advice in locally. Now, again, you will have your attendings to fall back on, and I used to call them then a fair amount early on, and over time I've have people locally that I discuss and talk, and I do still do send cases out when I need to, but it's very nice to develop that early on. I think what I learned from Greg early on was just having a partner that was or a colleague that was a neurosurgeon was very helpful because of just their input is and training is slightly different from ours. So I have connections with a lot of our neurosurgeon colleagues at Cedars that helps out. Now, in regards to surgery and decision making, what I learned is, early on, it's you're better off to be, I think probably in general, but just early on, better off to be less invasive than more invasive when you're making your surgical plans. If there's potential for a decompression as opposed to, decompressing and infusing, I think that will be the way to approach most patients. Again, you're going to sit there and talk about the goals of your surgical intervention. But I feel that, with that though, there will be times where you won't achieve the goal, right? Somebody has a, fractionated curve and you decide to decompress them or think that it may give them a chance and, probably needed interbody in there and, that you did not relieve their symptoms. I'm sure you explained that to them, but sometimes they just don't quite remember what you explained to them and they get upset. They sometimes go see another surgeon and that these things are going to happen to you for various reasons, but I would much be rather in that situation than you did a very aggressive surgery and that patient now has pseudoarthrosis or even worse other issues going on. So I think you're better off doing something smaller than bigger, especially early on. It's a reputation in the community that you want to develop that you're not an aggressive, overly aggressive surgeon. And as we've all trained, we know that if you start to develop an early reputation, sometimes it's very hard to shake that as things move forward. Next is, sorry, I think I typoed here, but just when you're involved operating with other surgeons, and this speaks more to my experience, which I think is a little bit different from others. When I started here at Cedars, the way you kind of start as an apprentice or a super fellow. You're part of a group, but you assist your attendings a lot, or assist a lot of attendings. I actually liked it a lot because I got to learn from a lot of different people. But I was thrown into a lot of cases, not knowing really what I was doing except just being a technician. Sometimes they want to help you out and say, hey, I'll make you a co-surgeon just to help your the finances of it. But I feel like these are things where if that's the case, like a co-surgeon, especially for boards, absolutely for boards, you will need to, you need to do your own assessment of the patient and make sure you agree with the plan. Okay. Because, there's, it still happens to me in other cases that I may be in there as a co-surgeon and, as an assistant surgeon, may not necessarily agree with the plan. I'm just there to kind of support technically. And then next is, you guys have had great training. And I feel like, unless the fellowship change, you're learning to do the right thing, that, just trust yourself, your plan and training. And, if something doesn't seem right, then, I think you have every right to say, hey, I'm going to sit this one out or, try to find another assistant. And then next, with clinic, the clinic has always been the bane of our existence for all surgeons, but as we transition now to having our own practice, this is where we get our patients. So you need to be sharp in the OR, you need to be sharp in clinic. I think, coming in at Cedars, we all, for the most part, most people are dressed in suits, and it looks like we all got fitted suits at the same place. Yeah, I think the patients appreciate that a lot. I go sometimes in scrubs. I don't like to change in the middle of the day. So if I have cases, I'll show up in scrubs. If I am if I have clinic all day, I'll wear my suit. So, and I do get more comments on the suit days than I do the scrubs days. So I think the patients do appreciate it, and it sets a different tone, especially for younger looking physicians. If we try to look a little older, taking time with patients, I think, is going to be key, that you sit there and communicate with the patients, and understanding the communication level of different patients. Patients from the West Side area that are very educated patients, and I have patients from Central California who just aren't as privy to medical knowledge. So I think there's you just have to know who your audience is. Using spine models, media. I'm not a great social media person or posting, so that's not me. But I do keep a file of a lot of the cases that I've done, where at this point now I have a lot of similar cases, or there's a patient with a grade 2 unstable spondy. What does a lateral posterior look like? I have their whole pre-op, post-op imaging of another patient that I can show them, so that they're easily able to see what we do, and they appreciate that. Just with clinic right now, I would say the schedule that I run, and I think this probably be very different from Bob, is I see 3 patients per hour. That's kind of the way I set up my clinic. So it's a way for me to be able to keep up and not get too far behind. But that only leaves me about seeing 21 to 24 people per day. And that's kind of the max I can do myself. At this point right now, I don't have a fellow PA or resident helping me. So that's all me. And I got to do all the notes. So it seems like that. I mean, that's plenty for me. And then lastly, I would say to recommend discussing, the non-operative and less invasive options with patients. I've heard of patients say that they have gone with me when they've seen other surgeons, because I just brought up a less invasive or a decompression option. I bring it up and I say, I don't think it's going to work, or I don't think this is going to give us the longevity. But I bring it up. So I think they appreciate that you bring up those options as well. The rest was wanted to just leave some questions. I did have one more slide that I don't think made it here, but it was just in terms of kind of pearls for the next year as you start your practice. One of them was just to be patient. Okay, your practice will grow with time. I think the one common theme that I heard from Greg, Leonel Hunt, who's over at Cedars also, is just do the right thing for the patient. Okay. If you try to get too aggressive doing cases, it will catch up to you. If you just let it grow organically, with time, it will, your practice will grow. And the next is, I think, just being communicative with with referring physicians. Most hospitals will have a roster of new physicians that have been hired by the hospital, anywhere between like 1 to 3 years. I got that list from Cedars, and I just made sent emails to, internal medicine and hospitals just to say hi. And that was kind of an introduction I used to meet some of the newer physicians. I think that's was a great tool that I used that is available, will be available to most of you joining your groups. Thanks, guys.
That was awesome, Eddie. Thanks, dude.
Thanks, Ed.
Hey, I see Nick G on the call. Do you have any other things to add? Nick, you're sort of in the area in Los Angeles as well, but any thoughts, Nick?
Yeah, I thought that was very well put. He hit most of the really important parts. One other thing I can add is I actually learned this from Dr. Eastlack. I prepare for my clinic. So I send out a packet, and it can be done electronically too, and it says, where the pain is, when it started, what prior treatments they've had, and where they had their imaging. And so if I have access to most of the locations, and so I can, before the clinic, review the imaging, look at their symptoms, make an assessment, and put it into my EMR. My EMR allows me to go in there before I see the patient and kind of pre-fill things out. So that way, I'm going into this kind of knowing what's going on. I'm able to talk to the patient more, let them talk, and kind of, develop a relationship. And then I'm more confident with my diagnosis. And so that's been really a game changer. It does take a lot of extra time, but especially early on in your clinic, it'll allow you to see more patients, be more confident, and really kind of make the right decisions.
Awesome.
Any questions
Thanks,
from the fellows? Or Micah, Cody, as you're getting ready? Pick these guys' brains. They're right at the forefront. Well, Eddie, not so much. He's an old guy now.
Yeah.
No?
That was great. Thanks, guys. Appreciate
Great pearls of wisdom.
All right, yeah, and then if any questions or if you guys want to send anything to me directly, the guys all have my info, so please do so.
I'll make one other comment. You made a comment about the co-surgeon thing and seeing the patient ahead of time. I think that's really important and shouldn't be, because there's the practice end of it and learning and getting to know the patient, but the other end of it is medical legal. And if you're going to be a co-surgeon on the case, you should probably have something documented in your chart about how you discuss the risks, benefits, alternatives, convalescence, et cetera, with your patient. So if you're being asked to co-surgeon a case, or if it happens just in the middle of the operating room, I would personally say maybe next time, but it'd be great if I could, touch base with the patient ahead of time so I can document that. And then I would just take the assistant role, because even medical legally, if it comes down to it, there could be, implications from the decision making just based on the fact that you're a co-surgeon. So, anyways.
Hey, by the way, that unfortunately it doesn't protect you.
No, it does not. No, yeah, absolutely. It's just a level of involvement.
Yeah.
I feel like if I'm a co-surgeon, I have, you didn't even see the patient, you're a co-surgeon. Versus if you're the assistant, you kind of make sense that you're asked just to be there. So.